Good morning. Welcome to our series of CU sessions. Today, as a continuation of a couple of previous weeks' presentation, we will be dealing with something called as net reclassification index in a prediction model or a prediction study. So we'll have Dr. Joseph, who will be going through the basics and also critically appraising a study. And because the study also includes an AI component in it, so we thought we'll use the Probust AI checklist, which has been previously dealt with only recently, but we thought this will be an opportunity for a good refresher. And as well as we'll be focusing more on this net reclassification index, which has also been used in this article. So to present this, I'll once again hand over to Dr. Joseph for the presentation. Over to you. Thank you.
Thank you, sir. For today's presentation, the topic for today's presentation will be net reclassification index in a prediction model. The second part of the seminar will cover a Probust AI checklist for critically appraising a prediction model. First, coming to the synopsis of my presentation. In the beginning, I'll be just briefly discussing what is a diagnostic study and how is it different from a prediction model, what are all the measures of predictive accuracy we have at present, and in detail about net benefit and net reclassification index. And we'll also be learning about a new concept called the testing and treatment thresholds. Following this, we'll be looking into a case scenario, and we'll be trying to answer the case scenario by critically appraising a cardiovascular risk prediction tool using the Probust AI checklist. So how is a diagnostic study different from a prediction study? A diagnostic study is what you do in clinical practice, which is a cross-sectional study wherein before doing the test, you know what is the probability of the person having the disease. We do the test to find out whether the patient has the disease or not. And it is an immediate result. Whereas a prediction model, here the outcome has not yet occurred. And here we intend to find out what is the risk of the patient developing a particular outcome after a particular time interval. The study time frame is usually cross-sectional in case of a diagnostic study, whereas for a prediction study, it is a longitudinal study. The test result can be given as a positive or negative outcome or as a continuous outcome with regards to a diagnostic test, whereas in terms of in case of prediction models, the outcome is usually in terms of a risk group, in terms of low risk, moderate risk, or high risk. The outcome is given in terms of a risk group analysis. So what is the step in the assessment of a prediction model? If you have to do a prediction model, the first step would be to assemble a cohort, and the second step would be to use a appropriate model to assess the subject's risk of developing the outcome. The third thing would be to follow up the subjects and see how many actually developed the outcome. And then we do multiple measures to find out whether the machine learning algorithm actually predicted the outcome accurately or not. So how do we measure the predictive accuracy of a machine learning algorithm? In our previous sessions, we had actually seen multiple diagnostic studies, and we had learned about how do we measure diagnostic accuracy, especially in terms of sensitivity, specificity, predictive values, and likelihood ratios. Similarly, for prediction models as well, we have multiple ways through which we can assess predictive accuracies. One, in terms of calibration. Second, in terms of discrimination. What is calibration? Calibration helps us to figure out how well the risk prediction model matches the actual proportion that develop the outcome. Whereas discrimination, it helps to find out how well does the test differentiate between the subjects who are more and less likely to develop the outcome. Calibration is more used for continuous outcomes, whereas discrimination is more often used for outcomes which are in terms of yes or no. And first, coming to calibration, say, for example, you're working in the ICU as a doctor and you're trying to use a machine learning model to predict in-hospital mortality in sepsis patients. So you're feeding multiple clinical parameters, history, clinical examination, multiple laboratory data into a machine learning model. And the machine learning model gives you an outcome in terms of the patient having a low risk of mortality, a medium risk of mortality, or a high risk of mortality. So in this model, we have fed data for about 100 patients, and the machine learning algorithm has classified them like 50 of them to be at low risk, 30 of them to be at medium risk, and 20 of them to be at high risk. And the predicted mortality for the low risk population is 10%. For the medium risk population, it is 30%. And for the high risk population, it is 70%. So as per this predicted mortality and this classification, the expected deaths in the low risk arm would be 5. In the medium risk arm, 30% of 30 would be 9. And in the high risk arm, 70% of 20 would be 14. So Next, how do we assess the accuracy whether this machine learning algorithm actually predicted the risk correctly? We follow up and see how many actually died. Say, for example, in the actual deaths were 5, 10, and 13 as compared to the machine learning algorithm's prediction of 5, 9, and 14. Do you think this is a good calibrated study? Or say, for example, the observed deaths were 12, 15, and 18 in the low risk, medium risk, and high risk arms as compared to the prediction made by the machine learning algorithm as 5, 9, and 14. Which one would you think was well calibrated? Yes. So like you said, the first one is a well calibrated study, whereas the second, if the outcomes were completely different from what the machine learning algorithm had predicted, it means the study has poor calibration. So what calibration exactly measures is that it compares the predicted risk to the proportion that actually developed the outcome in subgroups of subjects. So how do we visually analyze the calibration indices? One such plot that we can use to analyze calibration indices is the Bland-Altman plot. How do we do a Bland-Altman plot? Here, we compare a new machine learning algorithm to a pre-existing model. Say, for example, in our scenario where we assess the possibility of death in patients admitted with sepsis in ICU, we have multiple numerous scoring systems like the Apache score or SOFA score, which are already available. Now we are trying to analyze whether a machine learning algorithm will fare better as compared to the pre-existing risk scores. So here, what we will do is we'll plot the predicted risk as found by the machine learning algorithm in the x-axis, and on the y-axis we'll plot the actually observed outcome. And if the predicted risk and the observed risk are equal at different thresholds, we'll be getting a 45-degree curve like this, and this will mean that the prediction model was well calibrated. And if we get, say, for example, this poly-ANA model, most of the values were above this predicted threshold, which will mean that the model had actually over predicted the risk. And in case, take for example, the Black Horse model, we can see that most of the values were under this threshold. So this means that this model had actually under predicted the risk of mortality.
So suppose the predicted risk was 10%, the green one.
Yes.
The first green one. No, whatever the dot.
Yes.
Diamond. Observed is 10%, but it's under predicted, right?
Yes. I told the other way around. Yes.
Below
lower predicted. I told the other way around. I'm sorry. So other measures by which we can measure calibration are the mean bias, mean absolute error, and the Brier score. So again, taking into account the previous example that I had shown, mean bias is nothing but we find the difference between the predicted and the observed values, and we divide it by the total number of values. Say, for example, there were 5 patients admitted with sepsis in ICU, and the predicted risk of mortality by the machine learning algorithm was as per this one, 0.1, 0.3, 0.6, 0.8. Whereas the observed outcomes can only be a hard outcome as yes or no. So the observed 0 is survival and 1 is death. So we calculate the differences between the predicted and the observed outcomes for each of these patients, and we sum up all the values and divide it by 5. So if we do that, we get the mean bias score of 0, which means that the model was perfectly calibrated overall. But is it actually correct that the machine learning algorithm was actually well calibrated? We'll be looking at in the coming slides. If we get a negative value in this thing, it means that the model had under predicted the risk of death. And if we get a positive value overall, it means that the model had overestimated the risk of death. The second measure would be mean absolute error, wherein instead of taking the values as such, we'll be using the absolute difference instead of the negative or positive values, so that we don't get a different outcome. And we will be dividing it by the total number of outcomes. So here, what is the advantage is that in case of extremes of value, say for example, the difference is from minus 0.9 to plus 0.9, the values will get equated against each other and the net value will be 0, and we'll be wrongly concluding that this is a well calibrated test. So if we do it as a mean absolute error, both the values will still be 0.9 and 0.9, so that we'll not be making a mistake of committing to the model being well calibrated. The third score would be the Brier score. Here, what is different as compared to the previous one is that instead of using the difference between the predicted and observed value, we use the squared value of the difference between the predicted and the observed value divided by the total number of samples. Here, how is it better from the previous one? It is that extremes of values will give very high differences, so that the models will give a very bad score for a model which predicts very poorly. So mean bias, the only advantage is that it gives the direction of error, whether the new model over predicts or under predicts the risk of death, whereas the median one will give the average size of error, and the Brier scores will give an estimate as to the overall accuracy, and it will also penalize for large errors. So next, coming to discrimination. Discrimination is how well does a test find out those who have the disease as compared to those who do not have the disease. There are numerous measures to which how we assess discrimination. One thing includes the area under the ROC curve. It can be in terms of risk ratios, hazard ratios, in terms of net benefit, or it can be in terms of net reclassification index, or it can be given in terms of integrated discrimination improvement. So we'll be seeing in detail about what these terms are. The first is what we have come across multiple times in the past, which is nothing but the area under the ROC curve. Here in x-axis, we plot the 1 minus specificity, and in y-axis, we plot the sensitivity. 1 minus specificity is nothing but the false positives in the test. Test is said to be very ideal if the point is as high in the y-axis and as close to 0 in the x-axis. So based on different thresholds, we can get many different values in the area under the ROC curve. So this is one example of a poor test, the poor discriminatory function, whereas the one in the below is a test with good discriminative function. Here we could see that there is a significant overlap based on the test result in differentiating the ones with the disease and ones without the disease. For this example, if we had to plot an ROC curve, we'll be getting almost like a 45-degree curve, which means that the test is not a good discriminatory test. Whereas in the second curve, we can see that both of these, the test result more or less helps to separate well the ones who are diseased as compared to ones who are not diseased. And here the ROC curve almost reaches 1, which means that it has good discriminatory function. And generally, a test is said to be having a good discriminatory function if the AUC curve is more than 0.9, and it is said to be good if it is between 0.8 to 0.9 as well. And if any values below that, we do not take it to, we do not consider it to be having a good discriminatory value. So next, coming to the new concept of what is treatment and testing threshold. So multiple measures of diagnostic test, we intend to find out measures of diagnostic accuracy like sensitivity, specificity, predictive values. But does it actually mean it changes outcome? Does it actually change the outcome for the patient? But does it actually consider the costs intended for the patient? Most of these tests for accuracy do not consider the factor of costs in them. So we'll be looking at this new concept for a diagnostic test to be considered as ideal. It should be cost effective and it should not be giving us wrong answers. So how do we decide whether to do a test in clinical practice or whether not to do a clinical test in clinical practice? So for this, I'd like to give 3 different scenarios. The first scenario is a 24-year-old male who has come with complaints of running nose and sneezing. He has no known influenza contacts. Examination is normal, and this is a non-influenza season. The second scenario is a 45-year-old school teacher who has come with fever, myalgia, dry cough for the last 36 hours, and there's also an ongoing local influenza outbreak. Otherwise, the patient has normal systemic examination. Whereas in the third scenario, this is a patient with diabetes and chronic kidney disease who has now come with high-grade fever, myalgia, dry cough for the last 1 hour, and the patient also has features of SARS, and there's also an ongoing influenza epidemic, and the spouse had also tested positive for influenza yesterday. So in which of these 3 patients would you test the patient for an influenza virus? Like, say, for example, would you like to do a multiplex viral PCR for influenza virus? And if so, in which of these patients would you do a influenza PCR testing? Okay, first one. Second one. Okay. Any other answers apart from this? Third one, okay. Okay, we'll look in the coming slides to find an answer to this question. So we have 3 options. One is to use the diagnostic test for influenza. Second option we have is directly treat the patient with oseltamivir because of high probability. And third option is don't test and don't treat because the probability of patient having influenza is very low. So we have 3 different options. We'll be seeing in the coming slides as to how to decide on these 3 options. So for this, I have just taken an example for rapid diagnostic test for influenza virus, which has a sensitivity of 75%, specificity of 95%, Using this, the positive LLR was 15 and negative LLR was 0.26. So this data alone is not adequate for us to decide on whether or not to test the patient. So our goal should be to identify the range of prior probability of disease for which the expected benefit of doing the test will outweigh the risks. For this, we'll be looking at 3 different new terms, which is called as C, B, and T. T is nothing but the cost of the test. Say, for example, the cost of doing this test is $10. C is the cost associated with unnecessarily treating a patient who does not have a disease, which is nothing but giving an oseltamivir course for 5 days, which comes to, say, for example, comes to about $60. And B is nothing but cost of failing to achieve the benefit of treatment for those who have the disease. So we wrongly took them as negative and we did not treat them with oseltamivir. The benefit might not be just in terms of drug. Patient might have not gone to work because of that. There might be loss of productivity. There might be loss of quality associated life years, which all should be taken into account. This will be termed as B. So when do we decide whether or not to treat the patient? So for this, I'd like to put across this graph. So what is PTT? PTT is the probability of the patient having the disease, and this is the line showing where we will not treat the patient, and this is the line showing where we will be treating the patient. I'll be explaining it in detail in the coming slides. So what is treatment threshold probability? The treatment threshold probability is nothing but the probability of disease at which the expected costs of 2 types of mistakes that we can make, which is nothing but someone having the disease and not treating it, and someone not having the disease and we ending up treating it, are balanced, where both are equal. And what is the expected cost of not treating a patient with disease? That we calculate by the formula of P into B. P is nothing but the probability of the patient having the disease, and B is nothing but the cost associated with not treating someone who has influenza. And expected cost of treating a patient without the disease is calculated by the formula of 1 minus probability into C. 1 minus probability is nothing but the probability of the patient not having the disease multiplied by the cost associated with giving the patient oseltamivir. So how do we calculate PTT? PTT is nothing but we saw that it is a probability at which both are equally balanced, which is nothing but PTT into B is balanced against 1 minus PTT into C, which means P into B is equal to 1 minus P into C. So when we rearrange these values, we'll be getting the treatment threshold odds, which is nothing but C by B, which is nothing but the cost associated with treating someone without the disease divided by the cost associated with not treating someone with the disease. So if you have to convert this odds into probability, it will be changed into C by C plus B. So based on this parameter only, we'll be deciding whether or not to treat a patient with oseltamivir. So I've considered some certain values for the C, B, and based on this, I've calculated the treatment threshold probability. Say, for example, the cost of unnecessary treatment, which is the course of oseltamivir, is $60. And I've taken the costs associated with failing to treat a patient with oseltamivir as $100. And for this C and B value, what will be the treatment threshold probability? This is nothing but 60 divided by 60 plus 160, which comes to about 37.5%. So what does this number mean in clinical practice? Then we can correct. So if after doing the test, if the we find out that the post-test probability of the patient having the disease is 37.5%, that is when you decide to treat the patient with oseltamivir. This is what this number actually means. So in reality, we'll be having 2 different thresholds. One is called as a no treat test threshold, and the second one will be called as a test treat threshold. If we get a value in which the value is less than the no treat test threshold, we'll not even be doing the test and will not be treating the patient. Whereas if we get a value which is above the test treat threshold, which means that the pretest probability of the disease is so high that even if you do the do the test, and even if the test comes negative, it will not change your management. You will anyway treat the patient with oseltamivir. So in these 2 scenarios, we will not be testing the patient for the disease. The ideal time when should we administer the test? It is when the probability of disease lies between these 2 values is when you will be doing the test. So applying these values, we had calculated that the probability of treatment threshold should be 37.5%. So if you had to convert this 37.5% to odds, it will again come to 0.375 divided by 1 minus 0.375, which is nothing but 0.6. So this is nothing but the odds of the patient. And next, what we'll be doing is we'll be dividing the likelihood, positive and likelihood ratios to get the prior odds. This is the posterior odds of the patient. We'll be converting it into prior odds. So how do we convert it into prior odds? We note that the posterior odds is calculated by pre-test odds into the likelihood ratio of the patient having the disease. So when we rearrange the formula, we get that we can get the prior odds by dividing the likelihood ratios by the posterior odds, which is nothing but 0.6 divided by 15, which is nothing but 4%. And for a negative test, the posterior odds by negative likelihood ratio gives a value of 2.3. And when we convert this prior odds into a prior probability, the values come as 4% to 70%. So what does this number tell you? So for a positive test, if the pretest probability is more than 4%, you will do the diagnostic test for influenza. And for a negative test, if the value is under 70%, we'll test the patient for influenza. And if your pretest probability of the patient having influenza is less than 4%, or if your pretest probability of the patient having influenza is more than 70%, in both the scenarios, we will not be testing the patient for influenza virus. When it is less than 4%, you will not treat the patient, will not test the patient either. Whereas if it is more than 70%, we'll not do the test, but we'll be treating the patient with oseltamivir. So in our prior model, we did not take into account the costs. What if we had to take into account the costs as well? So this is the decision curve that we had shown in the previous slides. So if you had to plot these values on a graph, we'll get this blue line. So we have found out that the no treat test threshold for our scenario is 4%, and the test treat threshold is 70%. So when the no treat threshold is less than 4%, we can find out that the no treat approach is actually less costly. So it is not worthwhile doing the test. Whereas on the other hand, when the pretest probability of the patient having influenza is more than 70%, here we can see that the cost associated with treating the patient is actually lesser than the cost associated with testing the patient. So in both these scenarios, we will not be doing the test. Whereas in the scenario between 4 to 70%, we can see that the cost associated with testing is actually lesser than the cost associated with not treating or treating the patient directly with the oseltamivir. So in this scenario, between 4 to 70% probability is when we'll be administering the test. So if you have to take cost into account, we'll be adding the cost to this graph so that the threshold will actually become more narrower. Okay. Next, coming to another scenario where we have a ideal test which has 100% sensitivity and 100% specificity, but it is a very costly test. Will you test the patient or will you not test the patient? How do you decide in that scenario? Here, if you had to put the specificity and sensitivity values, we can see that the values will automatically become 0. So the only threshold by which we'll be deciding whether or not to treat the patient is by the cost of the test. So how do we generate a graph for this scenario just based on cost of the test? We'll be calculating the no treat test threshold based on the cost of the test divided by the benefits of not treating a patient who has a disease. So here we saw that the cost of the testing for influenza was $10. And when we divided by the benefits of the harms associated with not treating the patient if they have the disease, which was nothing but $100. When we change it to a percentage, we get a value of 10%. And what is the test treat threshold for a test which has 100% sensitivity and specificity? That we can calculate by the formula 1 minus T by C into 100. Here again, T is the cost of the test. C is the cost associated with treating someone who does not have the disease. And when we calculate it for our scenario, 1 minus the cost of the test being $10 and the cost associated with giving oseltamivir for a patient who does not have the disease being $60, we get a value of 83.3%. So for a 100% sensitive test, 100% specific test, when will we exactly do the test? That will be when the pretest probability of the patient having the disease is between 10% to 83.3% for it to be practically useful. So these were the scenarios which we saw. First scenario was an imperfect test, which did not have 100% sensitivity nor 100% specificity, but the cost was very less. Here our no treat test threshold was 4% and test treat threshold was 70%. The second scenario was when we had a test which had 100% sensitivity and 100% specificity. Here our no treat test threshold was 10% and test treat threshold was 83%. And whereas in terms of an imperfect test and a costly test, when we calculate the values, it comes to as 17% and 57% as to when we have to decide to do the test. So, so based on these values, when which of these patients would you decide to do influenza PCR testing? Second one. So in patient C, the cost of doing the test is actually more than treating the patient. So we'll be directly treating the patient with oseltamivir. And in patient A, the risk of influenza being very low, even less than 5%, we would not be testing nor be treating the patient with oseltamivir. Whereas patient B is an ideal person who might have a pretest probability of around 50% to have influenza. This is when we'll be administering the rapid diagnostic test for influenza and treating if the test is positive. So next, coming to our main concept of talk for today, which is nothing but the net reclassification index. Again, I'd like to just recollect, test to measure predictive accuracy can be in terms of calibration indexes or in terms of discrimination index. And one such discrimination index is nothing but the net reclassification index. What does net reclassification index tell us? It is a metric which is used to predict whether adding a new predictor to an existing model or a new model as compared to a pre-existing model will improve the predictive accuracy of the test. So what is the goal of us in doing an NRI? We would like to find out whether the new model will assign a higher risk score to someone with a higher risk of developing the outcome, and the model should also assign a lower risk score to someone who will not develop the outcome. That is what is measured by the term net reclassification index. So it quantifies the difference in predictive accuracy between two risk models, usually a base model as compared to a model with an added predictor. So how do we calculate net reclassification index? It is nothing but the true positivity rate of the new model subtracted from the true positivity rate of the base model, which is in turn subtracted from the false positivity rate of the new model, subtracted from the false positivity rate of the old model. It actually measures the net increase in sensitivity, and it subtracts the net increase in the false positive rate. So how do we interpret an NRI? If an NRI is more than 0, it indicates that the new model is actually faring better. And if the NRI value is less than 0, it indicates that the new model is performing worse than the pre-existing model. So to calculate NRI, we calculate the NRI for the positive outcome, and we calculate the NRI for the negative outcome separately. We add up both values. And if the value is more than 0, it means that the new model is actually better. So we'll see an example as to how we calculate NRI. So say, for example, we are evaluating a machine learning algorithm to predict the risk of MI in a patient. And we compare it with a pre-existing risk score. Say, for example, we have the Framingham risk score to predict the risk of cardiovascular event. So on administering this machine learning algorithm, what did this algorithm do? It moved 30 of the participants to higher risk among 100 patients who had MI. Whereas among these 100 patients, it moved 10 of these patients to a lower risk wrongly. And say, for example, there were 100 patients who did not subsequently develop MI, and our model moved 25 of them to lower risk, which was actually correct to do. And wrongly, it actually moved 15 of them to a higher risk score, which is wrong to do. So what is a net reclassification index for this scenario? So in this scenario, when we subtract 30 from 10, we could see that the net reclassification was 20% higher. And in this scenario, we see that the difference in classification was 10%. So when we add up 20 and 10, we get a value of 30%, which means the new model for predicting the risk of MI is actually 30% more accurate as compared to the pre-existing Framingham risk score. So is net reclassification index the best index to assess discrimination? Not really, because there are some flaws associated with net reclassification index. The first thing is that the net reclassification index gives an equal value to both true positive rate as well as the false positive rate. And in the second thing, the cost associated with the test is not taken into account. And the third thing is that the proportion of population who actually have the outcome is not actually taken into account in the formula. And many times it has been showed that it usually yields a positive result in favor of the new risk marker, even when the risk marker was specifically designed to contain no new information as compared to the pre-existing marker. So to overcome the negatives associated with the net reclassification index, some newer methods to assess discrimination includes the category-free NRI. Here, this takes into account the proportion as well. So here, say for example, there is a model called the R1 model, and there's a pre-existing model called as the R0 model. And we find out how much proportion of the participants have the outcome positive with the new model as compared to the ones with the base model. And the second thing we'll calculate is the proportion of the patients with outcome negative population with the new model as compared to the old model. So how do we calculate category free NRI? Here we find out the difference in proportion between those who had a positive outcome as compared to those who had a negative outcome. So say for example, our risk score for predicting severe heart disease in the next 5 years classified 65% of the participants under a higher risk score in the new model. So the Q plus value will be 0.65. And in this new model, 40% of the new participants had incorrectly received a higher risk score under the new model, which gives a Q minus value of 0.4%. So what would be the category free NRI for this test? Is it a good test? Is it a bad test? How do we calculate? So for this, we'll be using the formula of twice the difference between the Q plus and the Q minus value, which is nothing but 0.65 minus 0.4. So 0.25 into 2 will be 0.5. So this means that the new test is actually better and faring better compared to the previous test. And the last discriminatory method that we'll be seeing is the integrated discrimination improvement, which is nothing but the IDI. And here, instead of proportion per se, here we'll be looking at the mean predicted risk for an outcome positive group under the new and old model, and we'll be subtracting it from the mean predicted risk for the outcome negative group under the new and the old model. Here, R1 stands for the new model, R0 stands for the old model, and plus stands for the outcome positive individuals, and minus stands for the outcome negative individuals. And this is again one another scenario wherein we are assessing a new sepsis prediction model in ICU patients, and our outcome is development of sepsis within 48 hours. Say, for example, the old model had a mean predictive risk for sepsis as 0.15, and the new model increased the predicted risk to 0.25. And the old model had a negative predictive risk of 0.08, and the new model had a negative predictive risk of 0.06. How much does the new model increase the diagnostic accuracy or the discriminative power by? For this, again, we use this formula of R1 plus minus R0 plus, which is subtracted by the R1 minus the R0 minus, which will be coming as 0.25 minus 0.15, which is nothing but 0.10. And this is subtracted from the negative risk, which is 0.06, subtracted from 0.08, which comes to 0.02. When we add both values, we get a value of 0.12. This again states that the new machine learning model is actually better in predicting sepsis outcomes as compared to the pre-existing model. So for all these models that we saw, we were aware that many of them had so many flaws. One of them was them not taking into account the proportion of participants having the disease. The second being the fact that cost was not taken into account in most of these models. So far, what is the most ideal way to assess discriminatory power of a new model is to do a net benefit calculation. So how do we calculate net benefit? Here we calculate the true positives of the test, and we divide it by the total number of samples available in the test, and we subtract it from the false positives of the test divided by the total number of samples in the test. The false positives of the test that we have found out, we corrected for a factor called as the C by B. What is C by B? C by B is nothing but what we saw in the preceding slides. C is nothing but the cost associated with treating someone for a disease while the patient did not have a disease. And B is the cost associated with not treating a patient who actually had a disease. So here we come to know that the cost per se is also taken into account, and then the proportion of patient is also taken into account in this model. So this estimates the clinical value of treating a population based on a risk model as compared to other discriminatory models that we saw, like the AUC curves. These are all more of statistical values that we get with the AUC values, whereas in terms of net benefit, we get to know whether the new machine learning model is actually clinically useful or not. The highest value that we can get is 1, and if the false positivity of the test is very high, we can even get a negative value with this test. So we'll be doing one practical example of calculating net benefit for a machine learning model. So the question here would be, should I start statin for a patient based on a predicted 10-year CVD score as estimated by a machine learning algorithm as compared to the Framingham risk score? Say, for example, in reality, when following up the patient for 10 years, 20 patients develop cardiovascular disease and 80% of the participants do not develop cardiovascular disease. And our machine learning model had a true positive of 15 and a false positive of 30. We'll assume that the threshold to treat to be 25%, which will give a C by B of 1 by 3. What do you think would be the net benefit of this doing this test? Would someone like to calculate and tell the value? So the net benefit of doing this test can be calculated by us entering these values into this formula. So the true positive that we saw was 15 and the false positive was 30. When we divided by the total number of participants being 100, and when we multiply it by the correction factor for the cost, which is 1 by 3, we get a net benefit of 0.05, which is positive. So this test is actually helping us clinically, and it is clinically useful. And how do we decide whether this test numbers is actually relevant or not? We also calculate the net benefit for a treat-all approach. Treat-all approach is nothing but using these numbers of 20 and 80 instead of 15 and 30. And when we use a treat-all approach in this formula, we get a net benefit value of minus 0.067. So the net benefit value of this machine learning algorithm is actually higher than the treat-all approach, which is nothing but the Framingham risk score. So we'll be using this test, and it is actually a clinically useful test. So next, coming to the critical appraisal and a case scenario. On a busy Monday morning OPD in general medicine, we come across a 52-year-old bank manager who has come in holding a file and multiple lab reports. His friend had recently passed away with a heart attack 1 week back. And in the lab reports, you have come to know that his LDL value was 141. And he has given you a history that he's a chronic smoker with a BMI of 27 kg per meter square, and his blood pressure is 138 by 88. His main concern is he at a risk of heart attack? And is there any way whether we can predict his risk of heart attack in the future? So how will you answer this question? So the question that we'll be trying to answer today is, will a machine learning algorithm for predicting the risk of MI based on an Asian population fare better as compared to a traditional scoring system like the Framingham risk score or the RPCE score, which is mostly based on the Western data? So for critically appraising this, I'll be critically appraising this article published in PLOS in June 2025, which aimed to find out the cardiovascular risk prediction in the Malaysian population using a machine learning approach. And for critically appraising this article, I'll be using the Probast AI checklist of 2025. The Probast AI checklist assesses a test under 4 different domains, which include participants and data sources, predictors used in the machine learning model, outcomes in the machine learning model, and the analysis of the machine learning. So the steps in using the Probast AI checklist includes, first step would be to specify the intended purpose of the study and the Picot statement. The second step would be to classify the type of the prediction model, whether it is a developmental model or whether it's an evaluation model or whether it is both. The third thing would be to do a risk of bias assessment and applicability assessment. And overall, in step 4, we'll be giving an overall risk of bias score and an applicability score for the model. So first one, giving the Picot statement of the study. The population used in our study was a Malaysian population who were aged 18 plus with no prior cardiovascular disease. And they were recruited from a pre-existing cohort called as the Rediscover cohort. The index model that was planned to be evaluated was machine learning models based on multiple algorithms, which included random forest model, XGBoost, SVM, neural networks, and the logistic regression. The comparator model used was Framingham risk score and revised pooled cohort equations. The outcome that they aimed to look at was cardiovascular risk, both fatal and non-fatal cardiovascular risk at the end of 10 years. And the setting and intended use was in the community setting. So second step is to classify the type of prediction model. Our study is both a developmental model and an evaluation model. So we'll be using the combined checklist to critically appraise the study. So these are the signaling questions that we'll be answering. One for the participant level data, one for the predictors, third for the outcome, and fourth for the analysis. So the first step is to assess the quality and applicability or risk of bias and applicability. The first domain will be in terms of the participants. The first question would be, was appropriate data sources used? For this, I have given a yes because the data sources was used from an ongoing prospective cohort in Malaysia called as the Rediscover cohort, which spanned between 2007 to 2017. From this Rediscover cohort, they had chosen about 6,130 eligible participants who are between 18 years of age and above and who had more than 10 years of follow-up data and who were recruited between 2007 to 2011. And they had excluded about 500 participants in the study because of missing data in the variables. And finally, the net number of people recruited in the study was 5,688. In this 5,688 participants, clinical data was predictor valuables were sent into a machine learning algorithm to predict the cardiovascular risk. So the participants here in the study were recruited using aid of local community leaders by announcements and written invitations. It included both urban and rural areas in Malaysia. The follow-up intervals was at every 3 years, with a mean total follow-up of around 12 years. So the second question was an appropriate study design used? For this, again, I've given a yes because the study was taken from an ongoing prospective cohort, which was Rediscover study, and the loss to follow-up was also not more than 10%. And the third question was, did the in and exclusion criteria of study participants result in a representative data set? For this, I have given a yes because within Malaysia, they have made sure that there is adequate representation of multiple ethnic groups, including the Malaysians, Chinese, Indians, and the indigenous peoples. And the inclusion criteria was also fair enough. Anybody aged more than 18 years without any prior cardiovascular risk was eligible to be part of the study. And these are the baseline characters of the study participants. The overall females were more than males, and 11% of the participants were smokers. The average weight was around 64 kg. The average systolic blood pressure was 135. The diastolic pressure was 80. 10% of the participants had diabetes, and 24% of the participants had hypertension, and 40% had a family history of hypertension. 26% had a family history of diabetes. And when they had divided the baseline population into those who had a cardiovascular event at 10 years and those who did not have a cardiovascular event at 10 years, a significantly higher proportion of the participants were males with a higher proportion of smoking, higher percentage of diabetes, and higher systolic blood pressure. And they also had a higher incidence of underlying hypertension with a lower HDL score. So overall, considering all these factors, what is the concern regarding quality of selection of participants and data sources? I have given a low risk of bias because overall, I feel that the participants were recruited appropriately. And when it comes to applicability concerns, whether the included participants actually match the our review question or our intended use population, we also expect our population to be in a similar age group with a similar proportion of smoking, diabetes, and hypertension risk in the baseline. So I've given an applicability concern to be low in this setting. So the second domain that we'll be assessing is in terms of predictors. The first step would be to list and describe each of these predictors included in the final prediction model, how they were defined and assessed, and when were they assessed. So what all variables was collected in the study? Variables are nothing but predictors which were collected prior to the machine learning algorithm being utilized. The study assessors had collected details about the demographics of the patient, age, like gender, age, and residence. They had collected medical history and found out how many of them were diabetic, hypertensive, how many of them had deranged lipid profile. They had also assessed family history of cardiovascular disease, hypertension, diabetes, and strokes in the past. And they had also assessed details about what are all regular medications they were on. They had also assessed anthropometric measures like BMI, height, and waist and hip circumferences. They had also done clinical measurements like blood pressures and pulse rate. And all participants who were recruited in the study were asked to fast for a period of 8 hours. And they had underwent blood sample testing, which included lipid profile assessment and blood sugar assessment. So what are the problems in these predictors? Are these values accurate? There is a possibility that the study authors have told that they have collected medical history and family history from what all the participants had reported. So here there's a possibility of there being recall bias, where the participants might have not been able to recollect their medication history or their family history in detail properly. So, and the study does not state as to how they address this recall bias. And with regards to anthropometric measures also, they have not clearly stated as to what, did they use any standardized equipment to measure, how exactly did they measure. All the details are not provided in the study material or in the initial cohort study. And in terms of laboratory parameters as well, they have not provided as to what type of assays did they use and whether it was a standardized assay or not. Even in the rediscover cohort study also, it is an ongoing cohort and it has been planned for 25 years. So we don't have data as to how exactly all these parameters were measured in the beginning. So for the first question, were predictors defined and assessed in a similar way in all participants? I have given a no information. And for the second question, was any pre-processing of predictors similar for all participants? Here they did not discriminate participants as to whether they had or did not have an outcome. So I have given an yes to this question. And the third question, were predictor assessments made without the knowledge of the outcome data? And was there any pre-processing of predictors done? For machine learning, how does a machine learning algorithm differ from risk score? Risk score is a fixed formula by which we calculate risk score for any participant, whereas a machine learning algorithm is nothing but here a system is in place and it learns from whatever data we feed it, and it keeps learning from all the data that we feed it, and it keeps changing its risk prediction measures as well. So what risk we get today might not be the same risk that we get from the same model a few days later. So before we feed the data into the system, it is necessary that we adequately process the data so that the machine learning algorithm also gives an adequate risk calculation for the underlying cardiovascular risk. So how did the study authors pre-process the predictor variables before feeding the data into the machine learning algorithm? They had done certain things called as data splitting, data imputation, data balancing, and data normalization. So what is this pre-processing of predictors? The first thing that the authors had done was data splitting. What is data splitting? Data splitting, there are two ways to train an algorithm. One is to, first way is nothing but the entire variables are fed into the machine learning algorithm, and the machine learns from the entire study participants, and there is no participant left on which the machine learning algorithm can train on. So that is not an adequate ideal way to do a study, because there is a chance of over predicting the risk, and there's a high risk of bias. So the ideal way to train a model is to do something called as data splitting, wherein if there is a full data set, say for example, we have 100 participants, we divide them into the training data set and the test data set. Say for example, we divide them 70% of the participants into the training data set and 30% of the participants into the test data set. So what will the machine learning algorithm do? It will train to predict the risk based on with the data available from the 70% of the participants. And whatever it has learned from this 70% of the participants, it will apply on the remaining 30% for assessing the accuracy of the model for predicting cardiovascular risk. And data imputation, the study authors had told that around there was about 30% of the variables which was missing in the final participants who were included in the study. So how do we assess, what do we do for missing variables in the study? That is something called as, we can use something called as, we can take the missing data as missing completely at random, or we can take it as missing at random, or we can take it something as missing not at random. We take it as missing completely at random if the data which is missing is independent of any observed or unobserved values. Whereas we should take the values as missing not at random if the missing values are potentially related to the missing data itself and there is a high risk of bias. Here in the study, the authors have taken the missing values as missing completely at random, which means to say that the missing values did not ultimately affect the final outcomes of the study or affect the final cardiovascular risk prediction of the study. The technique that they have used to correct for the missing completely at random parameters is something called as multiple imputation method, whereas if there is a multiple missing data, what the system does, it generates multiple different values which are possible for that outcome. Say, for example, if the outcome is data is diabetes, and the risk that we are checking is HbA1c values. The machine will generate multiple values, say, for example, ranging from 5 to 12, and it will do separate analysis with each of these outcomes. The average of all these outcomes will be taken as the missing value, and that will be used in the final calculation of the cardiovascular risk. So this is a statistical method used to correct for missing variables. So next, coming to the concept of random oversampling. So another problem with data set, before we feed the data set into a machine learning algorithm, is the probability of oversampling and undersampling. If the outcome that we are assessing is very low in frequency, say, for example, in our cohort, we could see that the final outcome, which is cardiovascular disease, was only about 3% of the entire number. So which means that 97% of the participants did not have an outcome. So if we are using this data to train the algorithm will most likely learn to detect those will learn to detect those without the disease, but it will not be good at detecting those who will ultimately develop cardiovascular disease. So one statistical technique that we can use to correct for this is something called as the random oversampling examples. That is nothing but this is the actual data that we have. The majority of our data was those who did not develop a CVD event, whereas only 3% of our study data set had actually developed a CVD outcome. So what we do is we impute multiple different values for those who actually develop the cardiovascular outcome in and around whatever values we have for the 3.5% of the participant who had actually developed the outcome, so that both the majority and the minority values are equally matched, like 50% here and the 50% there. And then we feed this data into the machine learning algorithm so that the test does not inaccurately predict the risk of a cardiovascular disease event. So by predictor assessments made without knowledge of the outcome data, for this I have given a yes, because here when they had measured the predictors in this study, the outcome, which is the cardiovascular event, had not actually occurred. And were the predictors included in the model available at the time the model was intended to be used? Yes, all predictors were available prior to the model being utilized. And what is the concern regarding the quality of predictors? What is the risk of bias? Because most of our answers, we had given an yes, I have given a low risk of bias for the domain on predictors. And what is the concern about the definition, pre-processing, assessment, and timing of assessment of the predictors in the model? For this, I have given a low concern for applicability, because whatever predictors they had chosen were clinically relevant, routinely available, and they were also measured at appropriate time points. The only concern was they are not accurately defined as to how exactly they measured each of these predictors. So the third domain will be the outcome assessment domain. Here we'll be required to describe the outcome, how it was defined and determined, and the time interval between the predictor assessment and the outcome determination. So what was the primary outcome of our study? Our study's primary outcome was the incidence of CVD events at the end of 10 years. And how exactly did they assess cardiovascular disease event? They had what they considered as a CVD was, they divided CVD into fatal occurrences and non-fatal occurrences. Under fatal occurrences, MI, stroke, heart failure, arterial rupture of an aneurysm, pulmonary embolism, arrhythmic death, and death after invasive cardiovascular treatment were considered as fatal CVD. And peri-procedural and non-procedural MI, stroke, heart failure, unstable angina, and atrial fibrillation not resulting in death were considered as non-fatal CVD. And how exactly did they measure whether the CVD happened or not? The study authors had looked at hospital records and national death certificates at every 3-year intervals to find out whether or not the participants had ultimately developed a CVD event or not. So the first question was, were outcomes defined and assessed appropriately? For this, I have given a probable no, because here they have assessed outcomes only based on death registry and hospital records, and they have not exactly clearly defined as to what exactly they defined as MI, what exactly they defined as heart failure, what exactly did they define as stroke, and even with regards to mortality as well, whether the existing national death registry captured everyone who actually died. For example, when we looked at data from the Malaysian government, we could see only 67% of the deaths were actually registered in the Malaysian registry. So it might have not actually captured the entire data per se. There might have been people who had migrated to other countries whose outcome might have not been captured. So for this question on whether the outcomes were accurately defined and assessed, I have given a probable no. The second question was were outcomes defined and assessed in a similar way in all participants. All participants of the cohort were followed up at equal intervals and were assessed similarly. So I've given an yes to this question. The third question was whether the outcome assessments were made without the use or knowledge of predictor data. For this, we do not have any information available in the study article. Whether the outcome assessment of cardiovascular event was based on the predictor outcome, whether the authors knew whether the patient had diabetes, what was the age of the patient, what is the smoking history of the patient, and based on that, whether they decided to take the outcome as yes or no, we do not have any information about it. And was the time interval between predictor assessment and outcome assessment appropriate? For this, I have given an yes, because the outcome was assessed at 10 to 12 years of follow-up, which is a fair enough duration for development of a cardiovascular event. And the predictors were also measured at baseline, hence I have given an yes to this question. And what is the risk of bias? Here, because we were not clear as to how exactly they were assessing the outcomes in the study, the overall risk of bias, I have given a high risk of bias. And what is the concerns regarding applicability? Again, here for applicability concerns, I have given a high risk of applicability concern, because they have not given a clear-cut outcome definition, and there is no component-wise outcome reporting as to within this 202 people who had developed the CVD event, we have no data as to what exactly was the CVD event, whether it was a fatal CVD event or a non-fatal CVD event. And within this CVD event, what exactly was the CVD event, whether it was a stroke or whether it was a MI. Our outcome in question for our scenario was risk of MI. So we don't have data as to how many of them had actually developed a heart attack at the end of 10 years. The fourth domain that we'll be looking at is the analysis. The first step would be to describe the number of participants, the predictors, and the number of outcome events, and whether they were appropriate for the study. The participants that were included in the study were 5,688. Initially in the study, they had chosen to include 200 variables, and of which they had finally ended up choosing 30 variables. And they were further reduced using a phenomenon called as selective elimination of certain predictors. And the number of outcome events that they had got was 202. So whether this number of outcome events was adequate, for this we use something called as events per predictor. So if we are using one variable, we expect at least 10 outcomes to have happened. So here, if they had used 30 variables, they should have had at least 300 outcomes that should have happened for this sample size to have been considered adequate. Whereas here, the total number of outcomes was only 202. Hence, the sample size we felt was not an adequate sample size to adjudicate the risk of 10-year probability of them having a cardiovascular event. So the second question is how exactly was the prediction model developed, and what prediction model was used to find out the risk of a cardiovascular event. The machine learning algorithms that they had used included support vector machine, random forest model, XGBoost, naive Bayes, and neural networks. And to develop the final prediction model, they had also used certain additional models like the GLM, GBM, and RF model. What is GLM, GBM, RF? These are all integrations of multiple machine learning models into a single model. So these machine learning models will predict the risk of cardiovascular event based on the predictor variables that we feed it. And these three models, the final prediction models, will in turn use multiple machine learning models to assess the final risk of the patient having a cardiovascular outcome. And these three models are called as meta-learners. So this is the schematic diagram as to how exactly the study proceeded. The study authors had collected raw data. They had pre-processed the data before feeding it into the machine learning algorithm. They had split the data into the testing data and the training data. And in these data, they chose what variables to consider, what variables to not consider, and finally ended up with 30 variables. And they had fed these variables into a machine learning algorithms, which included SVM, LR, RF, and XGB. And subsequently, they used combinations of multiple machine learning models, which is called as the GLM, GBM, and RF models to finally decide as to what is the 10-year risk of the patient having a cardiovascular event. So what is predictor selection? And we'll be looking at one new term called as sequential backward elimination. So in clinical practice, for a risk score to be useful? Would you like the parameter to be having minimal parameters, or would you like to have a score which has many parameters? What do you think would be easy for us? So it'll be practically useful only if the number of predictors used in the risk score is actually less. Otherwise, it'll be time consuming. We might not be having enough time to be entering all those variables. So for finding out what exactly would maximally predict the cardiovascular risk, they use some phenomenon called as the sequential backward elimination. Out of the 202 variables that the study authors had initially planned to use, the study authors finally ended up using only 30. And even 30 seems to be a very huge number. So what the authors finally did is, they did something called a sequential backward elimination, wherein they take into account all the factors, that the 30 different factors, and they try to eliminate one factor at a time. So for example, we eliminate the triglycerides from the risk prediction model, and they will again assess the machine learning algorithm with only 29 variables and see whether the discrimination and the calibration indexes are same or whether it has significantly dropped. If the discrimination and calibration indexes remain the same even after removing the single variable, the next model will proceed with only 29 variables. So subsequently, they'll try to eliminate maximum number of predictors as possible, so to come at the least possible value. So the final model will have only the variables which maximally predicted the outcomes. So these are all the machine learning algorithms that they had used in the study. The first thing that they use is something called as a support vector margin. Support vector margin is actually a machine learning algorithm which aims to detect the plane at which there is a maximal separation among those with the risk and those without the risk. Say, for example, this is the group of participants who do not have a risk of cardiovascular event at 10 years. This is the group of participants who have the risk of them developing cardiovascular event at 10 years. So this machine learning algorithm will aim to find out this line or this plane, which is the point at which there is maximal separation between both the values. This machine learning algorithm is called as a support vector margin. So this SVM model separates by drawing an optimal boundary, which will maximize the margin between the closest data points. The second machine learning model which they used is the random forest model. What does the random forest model do? The random forest model will generate multiple decision trees. So here we have 30 variables. Using each of these variables, it will develop multiple combination of variables, and it will see whether which one of these variables actually predicts the outcome to be fair enough or not fair enough. And in the end, it will utilize all these multiple decision trees together and come together at a final risk prediction tree, and that will tell whether there is a risk of cardiovascular event or not. So it will pick up multiple random features, and it will develop multiple decision trees, and the multiple decision trees will be combined to make a single prediction. So this is the image showing the example of multiple decision trees. Say, for example, one parameter is LDL, one parameter here we use is HbA1c, one parameter here we use is systolic blood pressure. This will be combined with LDL again. And using this, multiple decision trees will be made. And finally, all these decision trees will be combined to make a final prediction as to what is the 10-year cardiovascular risk. And what is XGBoost? This is also another machine learning algorithm wherein we'll be having one tree will be used to generate the risk of them developing an outcome. And the machine learning algorithm will try to figure out what are all the errors, why all this model is not doing well. And it will learn from this algorithm, and based on that, it will repeat the process and it will form another decision tree. So from the second decision tree, again, it will impute multiple values, and it will find out where exactly are the errors, where exactly it is doing good. It will learn from that second model, and it will generate a new decision-making tree. And finally, it will come to a final decision-making tree wherein the chance of error is very low, and this will be used as a final prediction model. And the final machine learning algorithm that we will be seeing is the neural networks. Neural network is nothing but it is similar to how our own neurons function. So this is the cell body of the neuron. Here are the multiple inputs that come to the neuron using various dendrites. And the neuron has multiple hidden layers of analysis. And based on the multiple hidden layers of analysis, it gives an outcome as to whether or not the patient has a risk of developing a cardiovascular event. And how exactly the neuron functions, we'll not exactly be sure, because it keeps learning from multiple variables that we put in, and it keeps changing over time. So coming to the fourth domain of analysis, describe the performance measures of the prediction model in terms of discrimination and calibration indexes. In our study, what all calibration and discrimination indexes that they used is they have used only the area under the curve and the net reclassification index. They have not used the other discrimination and calibration indexes that we had seen initially before critically appraising the study. So these are all the models that they had used in the study, machine learning algorithms that they had used in the study. And here we could see what are all the parameters that were part of each of these machine learning algorithm. The ones highlighted in bold are the ones which had major impact on the final risk prediction of the machine learning algorithm. So say, for example, the logistic regression had predominant weightage to gender, glucose value, and HDL value at baseline. The SVM model had high value given to gender, glucose, and HDL at baseline. And the XGB model also, again, had most of the studies seem to have had a high impact of gender, glucose, and HDL at baseline. These are all the traditional risk scores of the FRS, Framingham risk score, and the RPC model, in which the parameters included are gender, age, smoking status, systolic blood pressure, diabetes, total cholesterol, and HDL values. The RPC score additionally had a scoring system which included the hypertensive medication that the patient was on. This is they had some additional components to it, and there were some specific parameters which they had used in the study to calculate logistic regression. And finally, these were the final AU-ROC curves that they got for multiple learning models. And finally, they had found that the ROC curve was perfect for the best ROC curve was obtained for the LR model with selected features, which gave an AUC value of 0.769, as against the 0.716 value of Framingham risk score and 0.74 obtained with the RPCE score. The other models were also fairly accurate enough, but the highest area under curve was with the LR model with selected features. And this is the sharp value curve, which signifies what exactly had major contribution to the machine learning algorithm. If the curve is wide, it means that the majority of the final prediction value depended on this predictor variable. Here we could see the widest parameters were blood pressure, weight, and waist circumference, with some contribution by HDL at baseline. So these were the four features which had actually contributed to the risk prediction of the LR model. So the next outcome that they had looked at to see whether this model outperformed the Framingham risk score was a net reclassification index. And as we had seen in the previous beginning of the presentation, here we intend to find out those with high chance of outcome, how better did the model actually tell that they have the disease? Did it correctly upgrade them as having high risk? And in those who did not have an outcome, did it correctly classify them to have had low risk? So here, as compared to the Framingham risk score, we can see that this new model based on the LR score actually increased the risk for 5 participants who actually had the outcome, and it wrongly decreased the outcome for 14 participants who had actually developed a cardiovascular event. So the net reclassification index for this group of participants who had an outcome was minus 15%. And in those who did not have an outcome, the algorithm had actually wrongly shown as high risk for 67 participants, and it had correctly shown as reduced risk in 530 participants, which corresponds to an NRI score of 28.15%. So when we add both these values, we get an NRI value of 13.15%, which means that the risk model was actually better than the Framingham risk score. And again, if we had to do the NRI classification for the RPCE score, the NRI for the positive outcome was 8.33%, and NRI for the negative outcome was minus 1.3%, resulting in a net NRI of plus 7%, which again meant that the new model, which is based on the LR, actually outperformed the model which is based on the RPCE score and the Framingham risk score. So first question was there evidence that the sample size was reasonable? As I had told previously, the event per predictors was actually 7, which is less than the rule of thumb, which says there should be at least 10 to 20 events per predictor. So the sample size was not adequate. And where contiguous and categorical predictors handled appropriately, they have used mean and standard deviation for the continuous variables, as well as frequencies and percentages for categorical variables. And for For the third question, were participants with missing or censored data handled appropriately? For this, I have given an yes because they have used some data imputation techniques and they have taken the missing data as missing completely at random. And they have also shown two different analyses using the missing data separately and with the imputed data separately, showing a similar AUC curve. Hence, I have given an yes to this question. The fourth question was if methods to address class imbalance were used, was the model or the model predictions recalibrated? For this, I have given a probable no because they have addressed class imbalance using the technique of random oversampling, which I had shown previously, in which they had oversampled the underrepresented group, which had cardiovascular event, but they have not per se recalibrated this model per se based on the new data set in the study. And were methods used to address. And next, coming to something called as the cross-validation. To avoid the possibility of our model overfitting, we use something called as a cross-validation. What is cross-validation? If we use only a single data set and if we train a machine learning algorithm just based on a single data set, there is a possibility of us ending up doing overfitting, which is nothing but the machine model will actually look very accurate, but when we employ the model in real world scenario, it will not be accurate in a new data set. So how do we make sure that our machine learning algorithm avoids this problem? We use something called as a cross-validation approach. It is nothing but what we do is we have a data set with about 100 participants. What we do is we use multiple different data as training data sets and testing data sets. Say, for example, we use the first 20% of the data as a test data set. And then we train the model based on the remaining 80% of the participants. And then we get a performance value from this one. The second part of the protocol, what we do is we use the second 20% of the data set as the test data set and the remaining 80% of the data set as the training data set. Using this five-fold cross-validation, we will aim to reduce the possibility of there being an overfitting of this model and thereby reducing the chance of it wrongly underassessing the risk of cardiovascular event in the future. So what is underfitting and overfitting? Overfitting is nothing but our model will perform well on a training data, but it will perform poorly on a test data or a practical data. And it leads to a high risk of bias. And if we just train the model with just one single data, there's a probability of the machine learning algorithm also learning the noise and the missing values as well. And there's a poor generalization to the new data as well. And what is underfitting? Underfitting is nothing but when we have a very small sample size, it's a very low event rate. And we have chosen only very less number of predictors. Say, for example, only five predictors we had chosen to train the model. The model will perform poorly in real world settings. So here the model fails to capture the underlying patterns in training data because we have fed the model with only very less number of outcomes and very less number of predictors. And here it will perform poorly in both seen and the unseen data. Whereas in overfitting models, it will apparently seem to be performing well on the test data that we have provided, but it will not perform well on real world data or on the test data. So was the model evaluation based on only apparent performance avoided? Yes, I have given an yes to this question because they have not utilized the entire data only for training the machine learning algorithm. They have split the data into 70% and 30%. 70% of the data they have used to train the model, and the remaining 30% of the data they have used to test the model. And they have addressed the issue of overfitting by using the process of cross-validation in this study. And was there sample size we have already covered in the previous question. And for the third question, whether the participants with missing or censored data handled appropriately, I have again given a probable yes to this question because they had done AUC analysis using both the complete data set, which had the missing variables, and the imputed data set, wherein they used multiple imputation methods to cover for the missing variables. They had attained almost similar AUC curves for both of these parameters. And coming for the fourth question, if the methods to address class imbalance were used, was the evaluation done in a data set without imbalance correction? Here, they have not done any separate evaluation in a data set with imbalance correction. So I've given a no to this question. And if data splitting was done to create training and data sets, was there an evidence that data leakage was avoided? For this, again, I've given a no. So what exactly is data leakage? So here we saw our study had actually divided the participants into a training data set and a testing data set. But we are not sure whether participants in the training data set had actually also been a participant, also had been a part of the testing data set as well, because the outcome is not essentially a fatal outcome. It is a non-fatal outcome. One person might have developed a MI, non-fatal MI, and subsequently went on to develop a non-fatal stroke. So that will count as two different outcomes. And we are not sure whether the two different outcomes, the participants are actually in the training data set only, or whether there was a possibility of data leakage and the participant being a part of both the training and the testing data set. So they have not addressed this possibility of data leakage, and hence I've given a no to this question. And if resampling methods were used to evaluate model performance, were all model development steps replicated in the resampling process? For this, I have given a no information because we do not have adequate data in this study. And for the 7th question, was the predictive performance of the model evaluated appropriately in terms of calibration, discrimination, and net benefit? Because they have given the AUC curves, diagnostic accuracies in terms of sensitivity, specificity, predictive values, and they have given the net reclassification index of the model, I've given an yes to this question. But overall, because two of these parameters we had given a no, the risk of bias will be high for this domain. So for this model evaluation, for the overall risk of bias and the overall concern for applicability, which is the final step in the Probast AI checklist, because two of them had a high risk of bias and there was high concern for applicability for one of this domain. For the overall outcome, for the model evaluation, I've given a high risk of bias and high concern for applicability. So when we try to utilize the study authors in the study have given a website as to how we can utilize this model for our practical use also. And they've given a link to this prediction model, which is free to use. But unfortunately, when we tried to utilize this, it had asked us to create an account and it had asked us to wait for approval and login. So far, we have not received approval. So I was not able to test and see this model actually. So given all these factors, for Mr. A, who had wanted to know is 10-year risk of him future risk of him developing an MI, given the high risk of bias and high concern for applicability, given the inadequate sample size, and given the fact that I did not know how many of them actually had an MI and the outcome was only 202, at present, I would not use this prediction model to assess the risk of him developing cardiovascular event in the future. So I'd like to thank Dr. Tambu sir and Vignesh sir for helping me with the presentation.